In the last part of Chapter 1, there's a little section on neurologic disorders and the neurologic examination. In the 5th edition of the book, they separate it out into a separate chapter, but basically the same information, just a little more detailed. We're going to talk about really the clinical application of learning neuroscience. That's what we're interested in therapy. Why do we need to know this? What information is it going to give us? So first we're going to define some terms, but for therapists the main purpose in studying the nervous system is to understand the effects of a nervous system lesion. So the lesion is an area of damage or dysfunction. Signs and symptoms following a lesion of the nervous system depend on the location of the lesion. So a lot of times the signs and symptoms will help you to locate the location of the lesion. Of course, as physical therapist assistants, we're not doing diagnosis and evaluation. However, it is nice to know these things so we know what we're working with our when we see the information that was done by our PT in the initial evaluation, or when we're trying to repeat some tests that were done on initial evaluation to see if there are changes on it. So depending on the distribution of lesions in the nervous system, lesions can be categorized as either focal, which is a lesion that's limited to a single location, multifocal, which is several non-symmetrical lesions. So but it's not all over the place, but they're non-symmetrical lesions, more than one. Diffuse, it affects bilaterally symmetric structures, but doesn't cross the midline as a single lesion. So a tumor in the spinal cord is an example of a focal lesion. A tumor that has metastasized to several locations is multifocal. And Alzheimer's disease, which is a memory and cognitive disorder, is diffuse because it affects cerebral structures bilaterally but does not cross the midline as a single lesion. So those are just examples of the 3 different types of lesions. But regardless of the cause of nervous system dysfunction, the resulting signs and symptoms depend on the site and the size of the lesion. Okay? So lots of different events may affect the nervous system, and those include trauma, vascular disorders, inflammation, degenerative disorders, neoplasms or tumors, developmental disorders, immunologic disorders, and toxic or metabolic disorders. So any one of those things can affect the nervous system. The incidence and prevalence of disorders, we talked about this a little bit in pathophysiology. It's a way of classifying disorders. The incidence is the proportion of a population that develops a new case of the disorder within a defined time period. It's typically reported per 100,000 people. So the example that's given in the book is that they asked 40 adults who developed a new dental cavity in the past year. Only 1 new case was reported out of 40. So they extrapolate that to indicate an incidence of 2,500 per 100,000. So 1 out of 40, and they extrapolate to 100,000. Prevalence, on the other hand, is the current proportion of the population with the condition, including both old and new cases. So, and that's typically reported per 1,000 people. So in the case of the dental cavities, the prevalence in that same group of people was 39 out of 40, indicating a prevalence of 975 per 1,000. So incidence is new cases developed within a defined time period. Prevalence is the current proportion of the population that has the condition, including both old and new cases. So in the book they talk about some different incidence and prevalence numbers, one of them having to do with migraine headaches, which they say have low incidence but high prevalence, meaning new cases aren't developed very often, but it's very common for people to have migraine headaches. So you can think of it that way. On the chart on page 20, I think it is, yes, the chart on page 20 has the incidence of selected neurological disorders. So it lists a bunch of different ones from amyotrophic lateral sclerosis down to tumors and varicella zoster. ALS is fatal. It's a fatal disease. And only 50% of people with ALS survive longer than 30 months after onset of the first symptoms. So the annual incidence of ALS is 1.5 people out of 100,000, so pretty low incidence. And the prevalence is 5.5 out of 100,000. So it's sort of a way of expressing how often things come up and are diagnosed as a new case of something, and then how much of it is in the current population. So I would like you to know those definitions. So the neurologic examination itself has two parts, taking a history and tests and measures. So we're going to test people and see what we come out with. So the history is a structured interview. One of the things that is defined in the history is the speed of onset. So it can be classified as acute, subacute, or chronic. There is a flow chart on page 21 in the book that shows the basic flow chart of a neurological exam, and then an example of one in the case of a spinal cord injury. So it's kind of interesting to look and see how that is classified. So an acute speed of onset indicates minutes or hours to maximal signs and symptoms. So I broke my leg and I have the maximal signs and symptoms minutes to hours from when it happened. So acute onset usually indicates a vascular problem. So bleeding, a clot, trauma, vascular problems. Subacute takes a few days to progress to maximal signs and symptoms. So subacute onset frequently indicates an inflammatory process like an infection or an infection. That's the example I'm giving you. Chronic is gradually worsening signs and symptoms continuing for weeks or years. So chronic onset often suggests a tumor or degenerative disease. So it's something that is going on over time. It's not a fast process. It's long term. So you can think of it in terms of time. Acute is minutes to hours, subacute is a few days, and chronic is weeks to years. Okay? So I would like you to know those as well, and given a case study, I would like you to be able to classify whether it is acute, subacute, or chronic. So in cases of trauma, the cause is usually obvious, like, oh, I fell while I was skiing and broke my ankle. I slipped on the ice and fell and broke my hip, that kind of thing. In cases of immune, toxic, or metabolic disorders, the speed of onset varies according to the specific cause. So some of those disorders can have a very quick onset. Some of them can have a slower, more chronic onset, depending on what the specific cause is. So the pattern of progression can be stable, where it's not changing a lot. So something like fibromyalgia tends to be a pretty stable pattern of progression. It doesn't really get any worse, doesn't get any better. Worsening is that it just gets worse and worse over time, and fluctuating, where it gets worse and it gets better, it gets worse and it gets better. So worsening, if you think of something like Parkinson's, that tends to have a worsening pattern of progression over time. Fluctuating can be like relapsing, remitting MS, where it gets worse and then it gets better, and then it gets worse again and then it gets better. So it's not a steady progression of worsening. So the purpose of the tests and measures for neurological examination is to determine the probable cause of neurologic problems so that appropriate care can be provided. So the PT is trying to figure out what is the correct plan of care for this patient. So for each test or assessment, the technique is described, followed by a description of the normal response of what structures are intact. So a lot of times we're looking for whether something is within normal limits or not within normal limits. So when you did your tests and measures with Claudia and Lisa this summer, we did some of the sensory testing, that's neurological testing, and a lot of times we're looking for what is the normal response. So when we have the normal response, what structures are intact? If we don't have it, well, those structures are probably not intact. So in the diagnosis, the therapist or doctor is trying to determine if the lesion is in the peripheral or the central nervous system, whether the signs are symmetric on the right and left sides of the bodies. Is it a focal, multifocal, or diffuse lesion? Does the pattern of signs and symptoms indicate a particular syndrome? What region or regions of the nervous system are involved? The probable cause, and then what is the diagnosis? So a lot of the things that are done are leading you down that path. A screening examination, neurological screening examination, has several purposes. So a lot of times this is done by a physician, but it can also be done by a physical therapist. First, you want to determine whether there is a neurological disorder, whether signs and symptoms are consistent with a given diagnosis. So often someone's diagnosed and then somebody else is evaluating them to see are their signs and symptoms consistent with that diagnosis. Whether or not you're going to refer a patient to another provider, so that comes up a lot. A lot of times with headaches, that's a really good example. We're saying, is this a cervicogenic headache caused by something in the cervical spine that can be treated in physical therapy? Or is there another cause? Do they need to be referred to a neurologist to be evaluated to see if they have a tumor? So a lot of times coming up with whether or not the person is appropriate for physical therapy or whether they need to be referred to another practitioner, that's really important. And then to determine what neural systems require more investigation. We might say, well, this is obviously a peripheral problem, but we need to see, is it a nerve issue? Is it a muscular issue? What do we need to look into after this? So the comprehensive neurologic examination looks at mental status, cranial nerves, autonomic function, motor and sensory systems, coordination, spinal reflexes, postural control, and gait. The comprehensive examination is supposed to give meaningful information for planning appropriate interventions. So by testing all those things, you can rule out things that you don't need to work on and focus in on the things that you do need to work on. So ordinarily, special tests are performed only when specific signs or symptoms are present. So if they're looking for a particular thing, they might do a test particularly for that particular condition. So as far as neurological versus orthopedic evaluation and treatment, there are special tests for orthopedic treatment as well. So there's special tests for shoulder impingement, there's special tests for a lot of different orthopedic issues. But the main difference between neurological and orthopedic therapy and treatment is orthopedic treatment tends to have a fairly standard recovery time. You can tell your patient you can expect to be better in 6 to 8 weeks or 10 to 12 weeks. If you know what the cause is, you can give them a pretty exact idea of how long it's going to take them to rehabilitate a certain problem. Say they have a rotator cuff tear, it's probably going to take them 10 to 12 weeks, all things going as they should. And your rehabilitation is going to be fairly standard. If they have a neurological issue, it's going to vary a lot more from person to person, and you're probably not going to be able to give someone a specific answer for how long is it going to take me to recover from this. For a really large neurological problem like a stroke or a spinal cord injury, they're going to be working on it the rest of their lives. So that's another difference. When you're working with neurological patients, you are frequently forming lifelong connections with these people, or hopefully. You're, as a resource, as a therapist, you are forming a connection with this person that you're going to work with probably off and on for the rest of their lives or for a very long time. And so you really do get to know your neurological patients. That's one of the really special things about working with neurological patients is it's not going to be just 6 weeks and then you never see them again. It's something that you're going to be working with them for a long time, hopefully, and you'll be able to help them through the things that they go through. So the categories of neurologic function are mental status. So is the patient alert? Are they disoriented? Are they confused? Cranial nerves, autonomic function, motor function, somatosensory function, coordination, spinal reflexes, and gait. And all of those things are tested in the neurological exam.